Segmental facilitation. We'll look at the definitions, the effects, and the treatment of facilitation.
This slide is just to demonstrate that I'm not making this stuff up. Somebody might be, but not me. However, segmental facilitation, which is an osteopathic concept mostly popularized by Irving Core, explains many observations and is a useful model for us. You can read through this slide if you really want to, but essentially segmental facilitation is where the segment's response to input results in an exaggerated response because of lowering of the threshold. The lowering can be normal as a short-term training response with repeated movements, or pathological, and of course we are more interested in the pathological variety.
There are actually two types of facilitation. One is normal neurophysiological facilitation, which happens day in, day out through your life, and the other one is the one that we're used to talking about, the pathological or dysfunctional facilitation. Normal facilitation is a training effect. It's also an anticipatory effect. If you repeat a movement or a series of movements 2 or 3 times, then the pathway is facilitated somehow and the movement becomes easier to do. This presentation will deal with dysfunctional facilitation, facilitation that's maintained and has nothing to do with the training effect.
The cause of pathological facilitation is generally described as chronic aberrant input into the segment by tissues innervated by that segment. How long is chronic is unknown and may have many determining variables, including intensity of the nociception, previous episodes, personality in response to pain, but I really don't know. However, aberrant input, which includes all input, does have the flaw of not explaining how inadequate proprioception results in reflex inhibition. Most false characteristics are at odds with those caused by facilitation. For example, hypertonicity and segmentality are characteristics of facilitation, while hypotonicity and locality characterize inhibition. Even the shared characteristic of non-fatigable weakness is different in that reflex inhibition results in breaking weakness, sudden giving way of the muscle, while facilitation does not. It could be argued that excessive mobility may cause facilitation, but I really don't know what excessive proprioception might look like outside of neurological disease. Even hypermobility is an inadequate input because there is insufficient proprioception for the restraining structures and for the range of movement that's available. So my thought is that nociception causes facilitation, pain causes more facilitation, while aberrant proprioception causes reflex inhibition. One of the things we have to do when looking for causes of facilitation is what joints can be stressed so that nociception now becomes painful.
So looking at the segmental effects, we see skeletal muscle hypertonus. This is due to a misreading of the interfusal fiber output and an overreaction to that perceived output, and with a correspondingly increased extrafusal fiber response. There's hyperesthesia. The patient feels more than usual, so pinprick feels sharper than it should do. This can also lead to dysesthesia, where instead of it just feeling sharper, it can also alter the sensation, so the patient may actually feel it tingly. And in fact, the paresthesia caused by segmental facilitation appears to be a result of dysesthesia. Stroking the skin may produce paresthesia, but it appears not to be a spontaneous or standing paresthesia. There's non-fatigable segmental weakness, presumably because of neuromuscular incoordination, because again of misreading of the feedback from the muscle fibers and muscle spindles. There's increased deep tendon reflexes for the same reason there's increased muscle hypertonus. There's increased tone in the blood vessels, and this leads to the next effect, trophodema. There's an increase in interstitial fluid within and under the skin, and this can actually be demonstrated with a small object that you can poke the skin and you'll see pitting over the skin. And there also seems to be an atrophic change in the skin. The skin takes on the appearance of an orange peel when it's bunched up. The clinical effects of these segmental effects, and they do occur throughout the segment, is restriction of active and possibly passive movement. The hypertonicity of the muscle restricts how much movement occurs. It also, and perhaps more importantly, alters the axis of rotation during movement, and this may lead to increased shear and torque applied to the joint, and then possibly damage to the joint surfaces or other structures. There's structural fatigue of the muscle due to its constant contraction, and it may start to break down. Adaptive shortening of the muscle is postulated to occur because it is never taken throughout its length. Personally, I'm becoming to believe less and less in adaptive shortening. There's myalgia from ischemia, and also possibly from the hyperesthetic effect, and there's palpation tenderness because of the ischemia caused by the hypertonicity, and again possibly also from the hyperesthetic effect. Hyperesthesia will cause palpation tenderness, and this may actually be the source of trigger points, or at least in some instances. There's muscle pain on contraction. This is particularly seen in the upper limb and around the shoulder in particular, but also at the elbow, in tennis elbow. And this can all lead to confusion in the diagnosis, partly because the isometric tests are often positive when they shouldn't be, and also because this is tender on palpation, leading you to suspect there are actual pathological changes within the tissue that's being palpated. Increased deep tendon reflexes. Again, if you're not careful, this will look like hyperreflexia. Just remember, it's in a segmental distribution, and it isn't true hyperreflexia, just an increase in the briskness of the response. You'll find no clonus within the reflex, and there'll be no other upper motor neuron signs. Non-fatigable segmental weakness. This can lead to failure to protect the joint, particularly during high amplitude or high ballistic, high velocity movements, and then the joint can break down. And again, it will lead to confusion in the diagnosis as segmental weakness. Just be aware though that the abnormal fatigability seen with a segmental palsy is not present in this case. Treatment. First off, if you want to get rid of facilitation, treat the cause of the facilitation, that is, get rid of the aberrant input into the segment, and this means dealing with whatever dysfunction is causing the facilitation. But you can defacilitate by any number of means. TENS, passive movement, active movement, massage, heat, traction, almost anything. Breathing on it reduces tone for a short period, and oftentimes reducing muscle tone is absolutely essential prior to the treatment of the joint dysfunction. Often much of the force of the mobilization is wasted in stretching tight muscle. In summary, segmental facilitation is an important clinical entity of probably common occurrence. It may limit movement, it may set up abnormal shear and torque, it may cause tenderness on palpation, and it may cause muscle pain on contraction. It's certainly got the ability to confuse the diagnosis, and it must be gotten rid of before you can effectively apply mobilization techniques.